Awesome. Thank you. Thank you very much. So I am Mary Maluccio. I run the New Orleans program, neuroendocrine program. And that is the program, sort of similar to Iowa. We're sort of in the middle of a space where you have a lot of people. I don't know how many people. One of the questions we should ask is how many of you cross state lines for your care. So we handle the southern part of the U.S., which includes Arkansas, Oklahoma, East Texas, Louisiana, Mississippi, Alabama, and the Florida Panhandle. And I think Iowa can probably say that they manage a good number of the surrounding states. And then I have my people from Indiana. So thank you very much for having me. I have participated in a number of these conferences. I think that for the newcomers, I think this is an extraordinary opportunity to know that you are not alone in your journey, and that the neuroendocrine community is one of those medical communities that is extraordinarily collaborative. None of us are really competing. We all get along really well. I think that all we really want is to raise the standard, get people good care, and bring clinical trials to patients that are sort of marginalized and disenfranchised. So I have the job of starting us off, and I was just going to go over sort of some net basics, and then I was going to end with what I consider are things that you should write down when you're going to your doctor, probably earlier in the disease continuum than when you have had it for a number of years. But I think that just a reminder of the types of questions that are important, because sometimes the types of questions you're asking are really not necessarily exactly to do with the case, but your case and the factors that go into your care. So the net basics. So what I want to achieve in this talk is that to really explain that few cases are exactly the same. And so really understanding where you fit in what I call the ocean of neuroendocrine, that if you go onto the internet can be very confusing, is super important. Someone will say, oh, I have a small bowel, and you're like, oh, I got a small bowel too. Well, the way we make decisions in those cases could be very different. And so it's not that a doctor in one case may or may not have the same type of training or the same type of insight. It may just be something about the case. And so when you follow some of the online chatter, I just want people to recognize that oftentimes there may be things about individual cases that are driving medical decision, even though the cases may be seemingly very similar. So I think it's really important to understand the drivers of medical decision making in particular cases. I think we will talk about tumor grade and stage. This is one of the few cancer diagnoses where the grade of the tumor is often more important than the stage. So, for example, a lower grade but higher stage 4, low-grade neuroendocrine, can often do better and have more treatment options and or a better outlook than a lower stage, higher grade tumor. The pathology report is probably one of the single things you should probably keep in your wallet, because that gives you valuable information about your particular case, and a lot of what is on that pathology report does drive medical decision making. There are many treatment options. I will briefly go over the treatment options, and then I think this is a really nice agenda, because then you have an expert in each of those fields going over then each of those options in a lot more detail. What's most important is they are not mutually exclusive. They can be used alone and or in combination. And if you were to look at philosophical differences between the neuroendocrine subspecialty centers, it is rarely about how we are interpreting the data, and it is more about opinions on sort of when we would bring in some of these treatments in any particular case. When a second opinion matters, I think in rare cancer diagnoses, it is never a bad thing to get a second opinion, even if it is going to have a person saying exactly the same as another person. Having two doctors tell you the same thing, maybe even using slightly different vocabulary, it gives you more confidence that the treatment plan that they have in place is appropriate for you. And then something that I think is near and dear to most of the physicians in this room is that in rare cancer diagnoses, clinical trials are super duper important for trying to bring even standard of care type therapies to patients that are sort of poor and disenfranchised and unable or underinsured and unable to get standard of care treatments. So the identifying key drivers of medical decision making, I mentioned the tumor grade, the primary site. So if you were to look at the data that supports a lot of what we do, where the primary is, regardless of ultimately the stage of the disease, drives a lot of the evidence that supports what it is we do. So even though we call it small bowel or we call it ilia, we actually really categorize them into foregut, midgut, hindgut, and then bronchopulmonary. Those are probably the four most common. It doesn't mean that there aren't even weirder diagnoses. I have had ones of the inner ear. We have ones of the thymus. You can get neuroendocrine tumors almost anywhere in the body, and each one of those is going to have unique features that drive how patients do. The extent of disease, meaning where is the disease both at diagnosis and or later on in the disease continuum. So what is the organ involved? Is it liver? Is it lymph nodes? Is it lung? Is it brain? Is it bone? So the extent of disease, the organs that are involved, because you got to look at the treatment options we have and the success of those treatment options in those organ sites. The avidity, so that PET scan that we talk about, and I'll talk about what that PET scan tells us, is that we call it avidity because that's the medical term for it, but that hotness on that PET scan matters. What I tell people is hotness on our PET scan is good. Hotness on the other type of PET scan that's done for cancer is usually indicative of a higher grade, more aggressive biology. So seeing that so much of what we do is targeting the somatostatin receptor, which is what that PET scan is showing us, the avidity or the hotness on that PET scan also matters. And then each of us walk through this life with our certain medical baggage, and therefore there are other conditions, there are other medical conditions and or medical problems that may affect your ability to tolerate some of the treatment options, making one treatment option particularly better in one case versus a different patient's case based on other medical conditions. This is something where people can live a long time, so we always have to sort of walk the line of not wanting it to be a trade-off of one problem, the current problem that you have, for a different problem that you would then ultimately have to live with for what can be a very long life. So the grade, we have them into low grade and high grade is sort of based on different features on the pathology report. How I describe it to people is the pathologist is looking under the microscope and he's either counting the number of cells that are trying to divide, that's called the proliferation index, and is a special stain they do, or the number of the mitotic index, how many of those things are in mitosis, kind of like going back to elementary school, science is. And so the low grade and the high grade are kind of two sort of distinct broad categories. Most of the data and a lot of what we discussed today has a lot to do with the G1, G2, and G3 well differentiated, because those are the ones for which we have a lot more evidence to support the standard of care treatments. When you get into the G3 higher grade poorly differentiated Ki-67s greater than around 30 to 50%, that is when we are talking about chemotherapy and looking at novel chemotherapeutics. Additional information, there is actually other information that you can get from your pathology report that really has to do with risk of either the development of metastatic disease or local regional recurrence. So if you were to look at the primary tumor, someone goes into an emergency department, they come in with an obstruction, they have to have an emergency operation. And for those of us that are often the recipients of the neuroendocrine patients after they've had an operation done elsewhere, how we gauge someone's likelihood of having either residual disease or their risk of recurrence in either local, regional, or metastatic is going to be looking at that pathology report. So the primary tumor, where it's located, but the number of positive lymph nodes. So we take out a primary tumor and then we take out draining lymph nodes. And if you have 2 lymph nodes that are involved and the surgeon in the course of that operation took out 10 lymph nodes, Well, that's going to give us more confidence that they have cleared that local regional area than if someone takes out 10 lymph nodes and all 10 are positive, because lymph nodes are like a spider web, and therefore you're taking it out based on just local regional drainage patterns, and so therefore we like to have at least a certain number of negative lymph nodes to assure ourselves that we got a really good cancer operation in the primary site. It does not mean that we go jumping back into surgery on a low-grade local regional, like maybe, for example, a mid-gut neuroendocrine tumor. It just means that the discussion that we have about either having residual disease within those lymph nodes or the risk of additional lymph nodes cropping up over time is just going to be one of the discussions that we have. When we don't feel that that perhaps we got as good a local regional resection at diagnosis, we are then more likely to get a somatostatin receptor PET earlier on to get a better understanding of whether or not there is residual disease there. Similarly, the margin status, that means that the pathologist looks and makes sure that the margins on the small bowel or the mesentery or the liver or the lymph node, whatever it is either positive or negative. And unifocal versus multifocal means that at the primary site, either in the pancreas or the lung or the small bowel, is it a single primary tumor or were there multiple tumors in the primary site? Because you have to think of neuroendocrines a little bit like having weeds on a lawn. If you've got more than one weed on the lawn, you may not be as confident that in removing one of those you have removed the entire thing. Vascular invasion means that under the microscope there is evidence that the cells have been able to access the vascular compartment. That increases the risk of the development of metastatic disease predominantly. Perineural invasion means that you've had those cells be able to invade through the neural structures. Nerves are a little bit harder to manage because you can't really understand the margin on a nerve. Perineural invasion makes us worry about local regional recurrences. And then the number and size of the lymph nodes, how we stage this in the lymph node world is going to be whether or not they are less or you have lymph nodes that are greater than 2 centimeters, and then obviously the evidence of metastatic disease. So the treatment options that I'm going to go through are sort of a whole menu. I talk about the whole menu of options, and then I will go over with patients all of the entire menu, including why one or the other option is more or less relevant to their case. But what's most important is that the treatment options are not mutually exclusive. So it's one time where if you were to decide one path for all the right reasons, even if it's your choice, it does not mean that in some time we can't go back to the menu and discuss the value of the other options. Somatostatin receptor inhibitors are a standard of care for somatostatin receptor avid tumors. I will go over what I believe is a pretty easy way to understand how those work. Liver-directed therapies is when we are directing treatment directly into the liver with a high local objective response rate. Those can come in catheter-based techniques called embolization, or thermal, or now ultrasound-based techniques that are ablation. Peptide receptor radiotherapy has gotten a lot of attention recently, as I think it is sort of evolving very quickly from what was previously done in Europe to now being available in the US. And just a shout out to Iowa, they're probably the program in the US that has been most proactive at really pushing getting PRRT and novel PRRT into the US. Chemotherapy, I think people understand chemotherapy, which is in no way am I in any way being flip about what medical oncologists do, but chemotherapy to a certain extent is trying to poison an entire being with toxic things in hopes of the cancer cells that have a higher division rate being more sensitive to that than the normal cells. But so chemotherapy most appropriate for higher grade tumors that have a higher proliferative index. And then obviously surgery, which is in neuroendocrine. We do approach surgery ever so slightly differently than we would in other types of cancer, like breast or colon or prostate. So this is my car and parking space analogy, because this is how I think people can get a better understanding of goals of care in in neuroendocrine tumors. So neuroendocrine tumors, especially the low-grade histopathologic variants, they have a receptor. It's called the somatostatin receptor, and it is what we are searching for on that PET scan. So the receptor, I call it a parking space, and then all of the things that are trying to stimulate that cell or block that cell are really cars searching for that parking space. So when I'm looking at treatment, it's a lot about how well are we able to either inhibit the ligand from signaling in that cell versus how well are we able to debulk or diminish the total amount of parking spaces that are available for those ligands to bind. And so when you trigger, and you're going to have natural chemicals that are going to go up in your bloodstream. Those are the cars. They're searching your entire body looking for that parking space. They're going to latch onto that parking space, and they're going to signal through this really, really complicated thing over here. They're going to signal that. And for people with really significant carcinoid syndrome, that can be a life-altering signal pathway. So our ability to try to inhibit and or downregulate that pathway is a good chunk of what it is we try to do. So somatostatin receptor inhibitors they're kind of analogs, meaning that we call them competitive agonists. They are competing for that parking space. So how I explain this to people in the South is that it's like injecting you with a bunch of little cars that are searching your entire body for that parking space. And like a police officer putting a boot on the car, it's trying to inhibit that cell. It's trying to cripple the cell, keep it from spewing out the stuff that gives you carcinoid syndrome, but also mess with the mechanism by which that cell divides. So somatostatin receptor inhibitors are a standard of care for patients that have a somatostatin receptor avid, meaning that they have the receptors there, and the goal of treatment is to delay growth over time. So if you have enough cars blocking enough parking spaces, you can actually keep this disease in check, or at least a low-grade histopathologic variant in check, for months to years of time. And depending on when you are diagnosed with the disease, this could be all that someone would need for their entire life. So somatostatin receptor inhibitors, or analog therapy, is a standard of care for patients with somatostatin receptor avid tumors. So that PET scan, when you look over here, is that when I talk about the PET scan, that's like injecting you with a bunch of little cars with a little pizza delivery light on them. You are injecting them just like you would anything else. They are driving around. They are binding to the somatostatin receptor. They are giving off a signal, and it is telling us how rich the parking space density is on that cell, and therefore how much somatostatin receptor avid disease that we have. Surgical resection. Now, I didn't do these in order. I should have just done them by the agenda, but then I couldn't have got my analogy thing going. But surgical resection is pretty primitive, but it has been around for probably hundreds of years. So surgical resection is pretty much like taking a shovel, and you're gonna go and you are gonna dig out a tumor, and that tumor is going to have a bunch of receptors / parking spaces on it. And so surgery is an awesome way to get rid of a ton of parking spaces from one moment to the next. I chose this because I don't have Iowa's data, but I pretty much think that Iowa has an equally awesome article on the role of surgical cytoreduction in metastatic neuroendocrine tumors. The reason why I put this slide on there is that for the most part, when you're talking about the data that drives surgical resection, the majority of patients are low-grade G1, G2, well-differentiated, and most of them are small bowel tumors. So the next most common is pancreas, but when we talk about the value of surgical cytoreduction, we just have to have a little bit more tempered expectations. Say, for example, if we were doing a surgical cytoreduction in a metastatic bronchopulmonary neuroendocrine, where we just don't have as much data to drive that decision. Doesn't mean we don't do it. It's just the conversation you have with the patient is that most of the data is going to be in small bowel tumors. So if you can then debulk or cytoreduce someone down to some amount, And it's not as if there's a difference between 69% and 71%. It's just that in our world, we have to have some threshold. So we all sort of agreed that if you can cytoreduce someone down to greater than 70% of their entire disease burden, then that is associated with a significant long-term benefit. How I look at it with my car and parking space analogy is that what we're trying to do is really take out enough parking spaces whereby the drug that we give you every month, which is the car and parking space boot on the car, is more likely going to be able to keep a lower disease burden in check for a longer period of time. So the programs that are probably more surgically assertive, which I believe are the Iowa and the New Orleans program, it's mostly because we feel if we can be surgically assertive up front, debulk down to minimal residual disease, then we are less likely to have to call in all the other therapies until much later in the disease continuum. But once again, that's philosophical. There's not necessarily that much absolutes about when and how you use surgical cytoreduction. So this is just a picture. I'm sure that Jim Howe will probably have much prettier pictures. So unlike other types of surgeries that we do for other types of cancer, I call this melon scooping. These are actually beautiful surgeries where these are well encapsulated, and you can often spare a lot of the normal liver, which is all this stuff here. Yes, and you literally are scooping the tumor out a little bit like melon scooping it out of a cantaloupe. And so you're able to come out with almost minimal harm to the normal liver substance and still debulk significantly the amount of tumor within the liver. Embolization is whereby an interventional radiologist is exploiting the unique anatomy of a liver, which is kind of like a tree. It's got a very predictable branching pattern. These tumors rely on the oxygen that comes from the artery, and therefore we are directing therapy through the hepatic artery in hopes of trying to really kill off tumor cells. So how I describe this to patients in the South is it's like going to the little arcade at the state fair, and you got your little air rifle, and you got the targets that come up, and the interventional radiologist is just pretty much trying to shoot air bullets and hit individual targets. And they can very successfully, with almost 80+% objective response rate, you can very adequately, with a less invasive technique, meaning non-surgical, less invasive technique, you are able to down-regulate or get rid of parking spaces using something that is not surgically. So embolization has been used to treat this disease for, I swear to God, almost like 40 or 50 years. The platforms have gotten a lot better, and I think that it's become much better tolerated. What I try to explain to people, which I think will go into more detail with the interventional technique talk, is the platforms that we use have varying degrees of advantages and disadvantages. And then lastly, PRRT. Lastly, this is chemotherapy. PRRT is where we are attaching a radiation particle onto that same car. So how I describe this to people is that you're taking the same car and parking space analogy. You're taking off the pizza delivery light. You're putting on the radiation particle. It is driving over your whole body. It is looking for the same parking space, but that radiation kills tumor cells or cripples tumor cells by damaging the DNA. So if we're talking about the difference between a beta particle like Lutathera versus an alpha particle that are coming down the pike, it's really just the degree to which that radiation particle is able to successfully damage the tumor DNA. So PRRT is a minimally invasive infusional therapy. It is a great strategy for managing multi-organ site involvement, and I think we have an entire talk on PRRT. So understanding where you fit in PRRT is also, I think, really important, as that is really emerging as a very promising therapy. And then chemotherapy is usually targeting higher grade tumors, cells that are dividing at a higher than average rate, balancing tumor cell death and toxicities. It's the standard of care for intermediate and high grade tumors. It is appropriate in over 50% of people with G3 well-differentiated tumors that progress despite being on the somatostatin receptor analog therapy. So chemotherapy is not something that is just utilized in patients with higher grade tumors. And as we are moving towards more next generation sequencing, that's when we test the tumor tissue for genetic mutations that would be appropriate to certain types of targeted, like the immune modulator therapy, is that as the tumor becomes higher grade, it likely develops mechanisms whereby it gets around the more common ways that these tumors grow, and in doing so, it is then more likely to have mutations that are potential targets for some of the targeted therapies. So I'm almost done. The definitions that I think are also really important if you are a new diagnosis and you're going in and trying to understand sort of the pros and cons of whatever treatment approach you're being offered. When we, as treating physicians and in particular surgeons, are talking about doing something with curative intent, it means that the procedure that we're describing to you is meant to give you every opportunity to be cured of the disease and to diminish the extent to what we can have a net specific event. If you have local regional disease and we remove all measurable disease, we as surgeons are doing that with curative intent. So that is no different whether or not you're talking about breast cancer or colon cancer or stomach cancer, is that in removing all measurable disease, we are trying to eliminate it as a variable for your entire life. The weird thing about neuroendocrine is you can do an awesome surgery and remove all measurable disease, and still there is a surprisingly high likelihood of the development of metastatic disease over the course of your lifetime, which is why the guidelines go up to following you guys for 10 plus years. So, but at the end of the day, there are, in certain situations, upward towards 40 or 50% of people that, with removal of all measurable disease, will not have a neuroendocrine specific event over the course of their life, and therefore they would be cured. So obviously curative intent is relevant to a number of different cancer diagnoses. But what's important is that the palliative intent and the prolongation of life are also actually super important in neuroendocrine. When something's being done with palliative intent, it means that whatever procedure we're doing is meant to alleviate a symptom related to the condition, so diminish the side effects related to anticipated progression of disease if it's in an awkward location, where the success of the treatment is not measured in quantity, but is measured in quality of life. So if someone has horrible carcinoid syndrome, then aggressively pursuing disease in the liver surgically or non-surgically and trying to beat down that disease burden. And if that alleviates carcinoid syndrome, we have met our endpoint of doing that procedure with palliative intent. So palliative intent is something that we actually talk about a lot in neuroendocrine, and it has enormous value, and perhaps Dr. Howe will go into that when he talks about some of the surgical options. The importance of palliative intent is that we don't do an operation with palliative intent unless we at least have something that we are trying to palliate, or else we won't be able to know whether or not we actually met the endpoint that we did. And then prolongation of life is also something that is not unique to neuroendocrine. That is that when we are doing a procedure, surgical or non-surgical, where the success of the procedure is associated with a longer expectation of survival than if we didn't do the operation at all. And I think there's a lot of data in neuroendocrine where what we do surgically, as long as we are conscious that we are meeting the endpoint, is that we would do it for prolongation of life. And we could potentially be doing to palliate intent, but that it won't necessarily be done with curative intent. But so therefore, when you're listening to people and say, oh, this is incurable, well, if incurable just means that you would have this disease over what might be the remainder of your life, even if you live to die of something else, it does not mean that all of the things that we're doing are not with palliative or the prolongation of life. And then lastly, the 5 issues that you should discuss with your physician is I think it's super important that you go in there with priorities. I think the way each of us would make decisions at different stages of their life is not going to be the same for every individual, even in this room. So I think that conversation, whether or not we call that an advanced directive or we call that just getting to know how a person makes decisions in their life, I think it's just really important for you to say, well, what are the priorities? Are the priorities to palliate some awful symptoms of obstruction, bleeding, perforation, carcinoid syndrome, or the potential to cause problems were it to grow in that site, well, that is definitely a priority. Or is it active cancer treatment where you are looking at quantity of life and what you are willing to invest in the process for a longer life, knowing that that may be associated with certain side effects of that treatment? I think it's important to say what are the unique drivers of medical decisions in your case that are supported by the data, and I think that's why it's so great to have different subspecialists talk about their individual compartments, whether or not that be surgery, PRT, liver-directed therapies. I think it's important to put multiple treatment options in perspective. I think for the most part, the subspecialty centers and cancer centers will rely on a tumor board. A tumor board is pretty much the checks and balances where you have all of us around a table saying, well, not so fast on the whole little, put the scalpel in your pocket maybe and talk about some of the data that drives other medical decisions. But I think tumor boards and how tumor boards discuss individual cases is really an important component of what it is we do. And then that multidisciplinary team are the people that sit around the tumor board and keep us all in line. In neuroendocrine, that can include people that are not necessarily always, cancer specific. People in general. Say for example, we'll have pulmonologists that'll discuss some of the things in bronchopulmonary. And then clinical trial opportunities. I think that's super important. I think as a neuroendocrine community, we're trying to make that information more readily available to patients. A little hard for you to say, oh, go on the NIH.gov website. It's got like 18 gazillion trials on it. It's a little hard to search that website for things that would be relevant to you. It's a little hard to even understand whether or not you would be eligible for those trials. So I think as a community, as we are all invested in bringing clinical trials to a more diverse community within the U.S., I think that are being able to get that information for you, NCAN and these types of organizations are, I think, really good at trying to get that information out there. And then nutritional type stuff, especially in some of the mid-gut neuroendocrines, some of the people post-pancreatectomy that may have some dietary and behavior modification that's required. Is I think that there are dietary and behavior modification that can help with symptoms and side effects of treatment. And I think that when you're looking at that multidisciplinary team, many of us do have nutritionists that will come in and sort of say, hey, not necessarily you're never eating a blueberry, well, we have blueberries right here, like in the high amines and all the things that you read. I think it's a very personal type of thing, but I think that in general, we usually say that neuroendocrine patients, especially those with carcinoid syndrome, they don't do well with intermittent fasting. You guys tend to almost be running a marathon, and then you hit a wall and you wonder where all your energy is. But they don't do well with 3 big meals a day either. So we're really usually telling you to eat really small, more frequent meals. Do a little bit like a marathon runner, where you're taking a little bit after each 4-mile thing, sort of try to keep you going over the course of the thing. But I think that those types of conversations that are treating sort of beyond the sort of active treatment that will be described to you today, I think understanding how you can just sort of behavior modify in your life is one that I think can sort of at least try to diminish some of what we call the burdens of a disease that you can have over probably 20 or 30 years. My advice is treatment plans for NET do need multidisciplinary input, and so therefore if you don't feel like you're getting the entire menu of options, I think that's a great opportunity to get a second opinion. Surgical oncology, medical oncology, radiation oncology, interventional radiology, there is a lot of people on that multidisciplinary team. I think most of the larger neuroendocrine programs have a full cadre of people that all sort of weigh into decision making in any particular case. I think that they give complementary recommendations. That's called a tumor board summary. A recommendation, this is going to be the surgeon in me, I think a recommendation for or against surgical intervention should come from a surgeon as the component of the multidisciplinary team. And so but it doesn't mean that the medical component or the PRT person is not sitting at that tumor board and listening to what the surgeon is saying. I just think that when someone gets a diagnosis of cancer, a lot of times they're like, can it come out? I mean, and so I just feel like if a surgeon is explaining that to you in surgeon speak on why you should or should not undergo something, or the risks and benefits of it in your particular case. I feel like that should be the searching component of it. Treatment can be used alone in combination. If I were to say anything, is that they are not mutually exclusive. Don't hesitate to ask teachers about the features of your case, not about neuroendocrine in particular, that go into treatment recommendations, and then keep copies of your records. This is when you move and things like that. It is very difficult for us to get back up to speed in people that have had a disease for 5, 6, 7 years and had a number of treatment. And so this is when I do recommend that you almost keep a folder at home that's got some of those key pieces of information, of which I'd say a previous scan and an updated scan and the pathology report are probably the 3 key features, but that these are all where all those things on that list are yours. You know, they are your medical record. You do not have to go to the medical record office and pay a buttload of money to get like 18,000 pages of every last thing that's ever been done. I think you need specific records that are indicative of the stage, the grade, the pathology report, some of the imaging, how that imaging is, and then PRT is sort of important because we got to understand just how much you've been exposed to. So I'll stop with that. There's always ample opportunity to ask questions between the sessions, but I think we're going to go on to the next one and we'll have the panel. Awesome. Thank you very much.